Well, good evening, everyone. Hope you're having a great summer. Um, we've been having a kind of a rainy couple of weeks here in Florida. Laura, how about on the other side of the bay?
Yes, absolutely. Right now, we got some thunder and drizzles going on. So it's our rainy Florida season, I'm gonna say, going on.
No hurricanes yet, and so we're hoping it's going to stay like that. Um, we're so excited tonight to have a special friend speaking to us and guest speaker with great expertise. And so we're going to wait a couple of minutes while we're letting some more people come in before we get started with our presentation. But uh, Dr. Manan Shah, who lives in Denver, is
Showing
going to be.
off. Look at that. What he's showing off right there on his computer. Look at all those
Yeah,
mountains we got to look at. We don't get to see
yeah,
that, Dr.
The
Shaw.
mounts? Oh! In the background, I was like,
yeah.
what am I doing? Yeah. I know
The high,
that's still that's.
the
Man,
highest
can I show you
elevation.
guys this?
Yeah, that's for
I don't
us.
know how to show this to you guys. Yeah,
The highest
I'm sure.
elevation in Florida, man, it's probably about 50 feet. And so,
Yeah,
um,
yeah, guys, it's beautiful out here. Although you guys were just out here.
yeah,
Um,
yeah, not
Great
long ago.
slideshow.
Um, where were you born and raised? Because I'll share with everybody where you went to school, and it was all east.
Yeah. I'm an East Coaster, so I was born in Maryland, and then went up to Boston for undergrad, then came down, went to University of Maryland for med school, and then I had met my wife in college, so we actually went back up north to University of Connecticut to be closer to her family for my training, and then um, after that we'd kind of decided we wanted to move west, and so we came out to Denver, and it's been honestly it's been lovely.
Oh, yeah. How many years have you been in Denver?
So we moved out here in 2019. I think we bought the practice in 2022, and man, the
Okay,
time goes by fast. Yeah.
about 7 years. Yeah. Oh, good for you. Well, I know you have a lot to share tonight, and so let's go ahead and get started, and we'll let other people catch up with us. But like Manon was saying, he was raised in the East, went to Tufts undergraduate in Boston, and then University of Maryland Medical School and University of Connecticut, UConn for residencies. And he's a board certified ENT and allergist specialist. So that's a great combination for very near the mouth and some of the things that we've been really trying to pay a lot of attention to, man, and as far as knowing that mouth breathers with all the medical dental problems that go along with that very, very often start in childhood with allergies and those congestions, and uh, then getting into tonsils and adenoids, and the breathing breaks down and the sleep breaks down and the health breaks down, and it's just a vicious downward spiral. Um, so Manon specializes in treating nasal problems and treating sinus problems and allergy type disorders. And so the other thing that's very important, and one of the reasons why we asked him to be our guest tonight, is that he and his partners have developed an online telemedicine allergy platform in which they can help us with our patients that may have allergies, doing remote telemedicine type approach, which is very unique. And also, as you'll hear, the approach to how he addresses these problems is very, I would say, non-invasive and very gentle, and something that would be really great for our patients. So, Manon, thank you so much for joining us. And please teach us what you think we might need to know and would help us to help our patients.
Awesome, guys. Well, listen, I appreciate everyone taking the time. And I've got a bunch of slides, but I always to try to tell people, if anyone has any ENT questions at any time, or if you have a tangential question, um, just stop me. Or think, I think I can see the chat. I don't know how to see the chat. Should chat previews. Um, I'm not good enough at Zoom.
I'll
Oh,
tell
I
you what,
can't.
I'll
Yeah,
watch the chat, and
yeah. If somebody
when
sees
you're
something in the
speaking, and
chat,
if
let me know.
something pops up, I'll speak up.
Sounds awesome. Awesome,
Okay.
guys. Well, the title of my talk is "Why Treat Only Half the Airway." And the reason I bring this up is because in the oral care community, there's a ton of focus on this sort of part here. But I would argue as an ENT, and I'm a little biased, that there's actually more volume of airway, you know, just a few centimeters above that is also part of this whole system. And so it's important to think about all of it together. And my hope is in this talk, we'll kind of talk about how you guys can think about it and potentially partner with ENTs to make sure you're treating the whole airway.
Mhm.
So I want you to understand how allergy plays a role, understand why screening is valuable, and identify patients. My conflicts, I'm the owner of the Colorado ENT Group, and I'm a founder at Whitley. Why should you listen to me? Um, I'm gonna go a little shorter. There's a bunch of uh, I do a bunch of stuff with the American Academy of Otolaryngology, and the President of Colorado ENT Society. I don't know, a bunch of people. I do a bunch of non-paid volunteer work for the Academy of ENT, but I think a more important reason is my mother is a dentist. This is her practice in Clarksville Crossing. It's done, and this is my little daughter. She's in the Vivos treatment for her airway expansion. So I have a deep respect for what you guys do and the care you guys provide to oral care patients. I grew up cleaning the suctions and being the front desk person for a dental practice. Um, sometimes the hygienist would be the one to pick me up from the bus stop if she was in the middle of a procedure. So definitely have a deep respect for what you guys do. And my dad was a general surgeon. So I always joke that if like a dentist and a general surgeon had a baby, an ENT is kind of what they would have. So ENTs and dentists are neighbors, right? We're separated by millimeters. So apparently someone did a study and measured the palate, and the thickness for the average hard palate is about 3 to 6 millimeters. So it's nothing. Um, and why is airway care important? Well, everyone, here today is an airway care provider, right? Um, the question is, which part of the airway are you focusing on? And I think that airway wellness is a huge part of the future. Probably all of you guys have heard about the book Breath. Um, Everybody has at some point heard of someone who's doing mouth taping. People are spending thousands of dollars on their sleep. Everybody wears a Oura in Denver, although I wear a thing called a Whoop. But we're all tracking our sleep. I think we're all beginning to realize that sleep and the airway are important parts of our health. And a third of Americans do not have a primary care provider. I actually don't myself. And patients will see their dentist or their oral hygienist or their oral care provider more than they will actually see their PCP. So everybody here on the study group has the opportunity to really play a huge role in patients' health because you have more influence because they're in your chair than the primary care doctors. And you can be a resource that patients are looking for to invest in their wellness. And so, why should you care about allergies? Well, mouth breathing is oftentimes, a thing that happens when people are unable to breathe through their nose. And the number one cause of nasal obstruction is environmental allergies. And when you have environmental allergies are blocking your nose, you breathe through your mouth, you lose all the benefits of the nasal humidification and filtration, and more pathogens and bacteria get into the airway, and it causes an issue. It also causes a bunch of dental and postural and structural issues that I think you guys can probably tell me about more than I can. And allergies are not just sneezing. They can cause cavities, poor sleep, mouth breathing, postnasal drip, congestion, throat clearing, crooked teeth, all kinds of things like that. And so here's a patient. I always like to start with the patient. This is Alex. He's a 37-year-old male. He sometimes feels like he's walking around in a daze. He's got brain fog. He can't focus. He's chronically tired. And, I saw him for allergies, but he probably sounds a lot like some of the patients you guys are seeing for sleep apnea or for sleep issues. And something I bring up to all of my airway care providers is if they're focusing on having patients use oral appliances, they will not work if patients cannot breathe through their nose. And allergy is the most common cause of nasal obstruction. And so there's this thing I always like to talk about called the unified airway theory. It's this idea that the airway is actually just one massive organ from the tip of your nose all the way down to the alveoli. The only reason it is broken up into dentists and ENTs and oral care providers and pulmonologists and gastroenterologists is really because it would be too hard for all of us to take a test on all this stuff. But at the end of the day, it's all one thing. And so allergic rhinitis is associated with sleep disorder breathing, dentofacial abnormalities, sinusitis, asthma, and even otitis media. So how's that the case? Well, it turns out allergens or pathogens come into your nose. They cause obstruction and inflammation of the tissues in your nose. That leads to your sinus ostia being blocked. You get mucus and backup and obstruction. You get this postnasal drip, which leads to pathogens coming into the airway. This leads to obstruction in oral breathing. And this leads to an inflammatory pathway that actually starts to circle back again. And so when you get allergens, it can lead to chronic sinusitis, It can lead to asthma from that postnasal drip. It can lead to otitis media because the eustachian tube is connected to the nose. If your nose is obstructed, you get sleep disordered breathing. And if your nose is obstructed, you breathe through your mouth and you get dentofacial abnormalities. And there's a huge association between allergies and obstructive sleep apnea. And it has a huge effect on its sleep. And allergen immunotherapy has actually been demonstrated to relieve the symptoms of sleep impairment. So we all know that nasofacial obstruction leads to dentofacial abnormalities. And probably all of us have seen a patient who kind of looks like this, right? They've got this sort of recessed jaw, this open mouth, their facial structure is underdeveloped. And this is the patient who's mouth breathing chronically, and so they just don't develop appropriately. And allergic rhinitis is a possible risk factor for malocclusion in these children. And one thing that's really interesting is allergic rhinitis also leads to inflammation of the tonsils. And so that's why if you look at this picture, adenoid hypertrophy, meaning if your adenoids get enlarged and you can't breathe through your nose, they will treat them with montelukast or mometasone. But guys, these are both allergy meds. And so what this study is saying in a backwards way is that if you have adenoid hypertrophy, it may be due to allergies. And so all these allergies are affecting patients' ability to breathe and sleep in an appropriate manner. And so is adenotonsillar hypertrophy associated with dentofacial morphology? We think so. We're not 100% sure, but it seems to, if you're not breathing through your nose, you can affect your dentofacial structure. So, okay, my hope is you guys believe me that allergies affect oral health. But the question is like, how big of an issue is it, right? Is it just a couple people? Is it a lot of people? Well, the CDC says 80 million Americans suffer from allergies. That is 1 in 4 Americans. Somebody on this call definitely has allergies, and they should tell me. And then it affects people in other ways. So 48% of visits to urgent care centers are due to sinusitis, upper respiratory tract, cough, and bronchitis. The other 10% are due to ear infections. And all of these can be associated with untreated allergic rhinitis. So it's a huge burden on the US healthcare system. It's great for ENTs, it's a good business to be in, but it's a big problem. And guys, allergies are increasing. If you remember your high school biology, plants respond to carbon dioxide as opposed to humans who, use oxygen. And for whatever reasons, there's more and more carbon dioxide in the atmosphere, and the pollen seasons are growing. So, my patients come in, they're like, hey, this is the worst allergy season ever. And I'm like, it is. Every year it keeps getting worse. So it's an interesting thing. What's the pathophysiology behind the allergies? Well, I'm going to skip over some of this because it gets real nerdy, but basically the allergen comes in, your tissue gets sensitized, you create mucus and it drips down and it creates inflammation. But the part that I think is valuable if you really get into it is like the first phase of the allergen is associated to the antigen presenting cell. You get IgE antibodies. So you get an allergen and you make antibodies. And then the second time the allergen is exposed to you, it binds to the antibodies and releases histamine. And histamine causes you to have a runny nose, sneezing, water eyes, congestion. But there's also this late phase inflammatory cascade, which creates systemic inflammation. And this late phase and this antibodies, this is something I'm going to be talking about later. So I just want to bring it up and highlight it now. The symptoms are pretty classic, runny nose, watery eyes, sneezing, teeth flaring, dental caries, mouth breathing, turbinate enlargement. And so, I think that my hope is that like ENTs and allergists are treating related issues. And my hope is, as you guys work together, we'll improve patient outcomes. And that's what we've been trying to do here in Denver is we've got great relationships with our dental colleagues here. And so we're able to get airway evaluations from them, and then we're able to send them back for non-surgical treatments and working on sleep. And it's been a really great collaboration. So allergies are a problem. Should I just refer to an allergist? So our job is to meet patients where they are. And the moment they leave your chair, your influence is gone. So my hope is that you guys can educate your patients to treat the entire airway, not just the bottom half. You can tell them that, hey, like this is where I focus, but you may want to think about the allergies. And I want you to talk to your patients about allergies. I love this slide that our team put in because it reminds me of if you're from the 90s, there's like talk to your kids about drugs. And so I want you guys to talk to your patients about allergies. And I want to teach you about how to treat them just so you can talk to them about it. The traditional model for allergy treatment is kind of broken. We ask people to come in, we stick them on the back 60 times, and we get paid for each one of these dots. So we're kind of incentivized to do a bunch of these. And then if they test positive, we tell them, hey, you should come in every week and I'm going to stick you in the arm. It's kind of a tough sell, right? 5 years of needles every week. But there is a better way. There's what's called sublingual immunotherapy. It's the same medication as allergy shots, but it's delivered orally under the tongue. There's research in the Journal of Allergy that shows it has similar outcomes, and it is used throughout the world, everywhere except for the United States. And it is safer than shots. There's a lower risk of anaphylaxis. So everyone has been told about allergy shots, but the question is, has anyone been told about drops? And there are evidence-based guidelines for allergic rhinitis. There's a clinical practice guideline, and then there's the international consensus. And the short answer is, your first step is identify triggers. So traditionally we do skin prick testing, but now we can do blood testing. And while the blood testing requires processing, it's a lot more comfortable for many patients. And there is good evidence to show that blood testing is equivalent to skin prick testing. This is from the international consensus statement, guys. And so what I want you guys to realize is traditionally we would tell people like you got to do the allergy shot skin prick testing. But there's good evidence that patients should be able to be tested however they want. So we do a blood test at Winley because we do all of our stuff telehealth. In my office, we offer skin prick testing, but given the choice, the majority of my patients choose blood. So blood testing works, but what about shots versus drops? So here's how immunotherapy works. I think if I showed you guys that slide in the beginning, the allergen binds to the antibody and you release histamine. But what immunotherapy does is it gives you a small dose of what you're allergic to, and over time, your body develops blocking antibodies. So the next time you're associated with an allergy, the blocking antibody binds it, and you never release histamine. So you end up being symptom-free without any type of medication. And there's there's two types. The traditional is the allergy shots. This is the in-office treatment. It's a once-a-week shot. It is covered by insurance. But the sublingual drops or the sublingual tablets, this is taken at home under the tongue, and it's much easier. And most patients tend to like it. And the American Academy of Otolaryngology finally, in May of 2023, came out and said, look, both can be used for patients. So it's been really helpful now that we have a guideline from an academy behind us. Let me get into the data because I think it's worth it. So what is the efficacy of allergy drops in adults? Well, a Cochrane review of 4,000 patients, 49 randomized control studies, shows that it decreases symptoms, decreases the need for medication. It's as good as intranasal corticosteroids, meaning sublingual therapy seems to be equivalent to Flonase, and it is actually better than antihistamines and montelukast. So it decreases patients' allergy symptoms markedly. Asthma, it seems to improve their pulmonary function test. And in terms of prevention, it decreases new sensitivities. So if you're on sublingual immunotherapy, your chances of getting more allergies later decreases. What's really cool in kids is it's almost the same benefits, but in kids, it can prevent new sensitivities. So what I'm trying to say is for kids, if you start them on immunotherapy when they're young, it can keep them from getting bad allergies when they're older, and it actually prevents asthma. Because usually what happens is that like inflammatory mucus in the nose drips down into the lungs and seems to lead to asthma later on. And it fixes multiple allergies at once. So it's a great treatment. It's cost effective. In fact, sublingual immunotherapy would be 50% cheaper for payers if it was covered than shots. So there's evidence that both of them, the shots and the drops, are worth it, and there's no superiority of one over the other. So here's the key takeaways. If your patients are, oh, sorry guys, somebody asked a question. So the key takeaway I want you guys to know is that if your patient has allergies, they can do testing however they want. And retraining your immune system is oftentimes better than taking pills or sprays every day. And why you? Well, it improves your patient's oral health if they breathe through their nose. So this is our patient who's chronically tired. And today he's sleeping better. He's able to enjoy the outdoors. He's not using antihistamines. He realizes his nose is meant for breathing. Like, what a cool outcome. So we're proud of the thousands of patients we've helped. We have patients who, this is a patient whose grandma had a dog and we fixed her dog allergies, and now she can go to grandma's house. So how do you identify a patient who might need allergy testing? Well, you guys are seeing these patients. They're going to be using antihistamines. These are patients who are unable to use their oral appliances, or they have nasal congestion, or the spring is bad for me. And so, these are patients like if they have obstruction or they keep having caries and you don't know why. Um, but a lot of airway dentists have an advantage. Do any of you guys have CAT scanners in your office? I guess I don't know if anyone's answering, but sometimes many of you guys might have a CT scanner in your office. And on the CAT scans, you can actually see the inflammation. So here's a normal inferior turbinate, nice and thin, and you can see inferior turbinate hypertrophy. The gray soft tissue gets enlarged. Here's another example of, again, this is the white bone, but you can see the soft tissue is incredibly enlarged. In inferior turbinate hypertrophy, in a review of it, you should always begin with medical therapy. So immunotherapy is like one of the first line treatments. Of course, you can do surgery, but you want to offer them medical therapy. And nasal septal body size is thought to be associated with allergic rhinitis. That's the septal swell, which is right here, and then you can see the swell here. So you can see on these CAT scans, sometimes these patients just don't have a lot of black air in their nose because their tissue's inflamed. That's going to tell you they may have allergies. So what are our key takeaways? Allergies are affecting your patient's airway and sleep. You can recommend allergy testing at your practice. And allergy treatment doesn't have to be about shots. There are actually easy home therapies. And our hope is that your practice can feel like the patient's home for their airway care. Because the truth is, once they leave your office, you tell them to go see somebody else. A lot of times, you know, they forget, they get busy, their life gets busy. And so one of the things we are proud to do at Winley is we actually offer allergy testing with our oral care providers. We will actually allow our care partners to have these test kits here, and they can be offered during an airway evaluation. So we have airway dentists and airway providers who are doing like a sleep study and they're doing an allergy test in their office. And then our team actually follows up with the results with the patient. So you know, it's a pretty great way of adding a comprehensive thing. There's home sleep studies, there's salivary testing, cone beam CT, and then allergy testing can be a great thing to kind of add on to it. So I don't want you to ignore the top of the airway. I want you guys to think about allergies. I want you guys to offer your patients allergy testing if it's appropriate. And then I just want you guys to know that you can offer blood testing in your practice. So that's the CME portion. And then I can tell you guys a little bit about Widley. But first, I want to take a question. Does anyone have any questions?
Yes. Um, a couple things, Manon.
Well,
One is you mentioned doing a blood draw or a stick versus pricks all over the back. So tell us the comparison as far as
yeah,
are more allergists doing that today around the United States? Is it new and small percentage of you all are doing that? What does that
yeah.
look?
I would say, a lot of times it tends to be more ENT versus allergists, right? You're going to find ENTs are far more likely to offer blood testing versus the allergists, or their system is like you come in, you get a skin prick testing. And there's nothing wrong with skin prick testing, but I would say you're going to get the option to do blood or skin more often at an ENT office. Does that make sense?
Yeah. Now, when you say blood draw, you're talking about a finger stick,
Yep. Yep.
okay? And you can get most of the information that you need from that.
Yeah. Yeah. So,
I think you told us before that the most common allergies will often show up in that.
yeah. So, in the finger prick testing that we do, you can test for the 48 most common allergies, which include trees, grasses, weeds, dust mite, mold, and dog, cat, and horse.
Okay. All right. And
Yeah.
then as far as the drops versus shots, so you're saying the research is showing that they're comparable, they're equal.
Yeah. Yeah. And that's like been newer research. So it's interesting. I think, our healthcare system in the United States is certainly more about visits, right? We get billed when we do a visit. In Europe, drops and sublingual tablets are far more popular because they're sort of like a preventative healthcare system. And so I
Mhm.
think some of it, unfortunately, is like just based on practice patterns. But what you will find is ENTs are certainly moving more towards offering drops because it's something the patients can do at home. patients don't always want to come into an office every week for 5 years. It's just painful and it's hard, you know?
Well, one of the things I find just as feedback is anything we can do in our office, I want to do because of the fact that when you refer, you lose them, or they don't go, or it takes
Yeah,
six
they get
months,
busy.
gets 6 months to get in, or a different conclusion. Um, so when we met you and learned about the fact that what you're doing is you can actually send a kit to our
Mhm.
office, and then we can do a finger stick and fill out a report form and send it
Yes.
back to you, and then there'll be a consultation.
Yeah,
Uh,
let me is my screen shown? Let
Go
me
ahead
show
and
you guys a
explain
little bit.
that
Yeah.
because it's
Yeah.
it's so streamlined. We're trying to use, any kind of hack we can to make
Yeah.
life easier and to get solutions faster and better. And the reason I asked you to come on tonight is because I really think you're brilliant and onto some things that pretty much like many of us that are on this study club meeting that we want to learn the newest things. We're not pushing back. And so
Yeah.
you obviously are in that place.
We appreciate it. Yeah. So Winley started from this is my physical practice, the Color ENT group. It's actually an old dental practice. I'm sure you guys have seen this somewhere, this like architecture. But we had this idea that we could treat our allergies, we treat patients' allergies from home. And it came about during the pandemic when all of our patients wanted us to start mailing them their sublingual drops. And we've got this really, we've come together with a great team. We've got Brian Danza, he's the head of rhinology at Case Western. Zara Patel, she's the director of the rhinology fellowship at Stanford. Nate Brady is a great board certified allergist. And we wanted to figure out like, what could we do if we wanted to build, the best allergy care program we could. So we're a virtual network of physicians. We provide allergy immunotherapy for environmental allergies. It's across all 50 states. There's 300 appointments available next month if anyone wants them. And it's just like a really great way of seeing an allergist that's good for busy travelers, patients, or people who are needle phobic. And we actually, I used to, go around and ask people to come to us. And then we would meet with them and we'd ship them a test. And my mom was like, you should just like ship it to my office because my mom's a dentist. She was like, once they leave my chair, they're busy, life gets busy. Just put it in my office. I'll do the test, and then you can schedule a Zoom result because everybody wants to meet with you to get the results. And so that's what we've now done. We can actually ship this entire kit that we used to send to patients' houses to our airway colleague partners, and they can do the allergy testing directly in the clinic. And then, they get the tests, they identify patients that might have environmental allergies. Patients take the test, and our doctors provide the follow up care. It's very simple. So we pinpoint their allergy triggers, we make sure a real physician meets with them, and then we send them their allergy medications directly to their house. And every test includes like a free consultation, excuse me, and a personalized treatment plan. And the immunotherapies for like 330 a day. So I think it's about like 99 bucks a month. And so it's less than a cup of coffee a day for a lifetime of relief. And honestly, that's probably cheaper than you're going to pay in copays if you were getting allergy shots.
Okay.
And so our partner lab provides the kits for your charge. They bill $200 a month in the use. Practice will sometimes charge an extra 50 to $100 for the DA time just to consult them. And it's still probably cheaper than the $400 to $500 that the patients would be spending on like a consult and a specialist. And then we always meet with the patients for free. It's part of the test kit.
Mhm. So there's a movement, I think, going on, and Laura, you can chime in here. But what you're doing with allergies, um, and as a physician and working with other specialists, including the specialty of dentistry, let me have Laura just mention what you're doing with Dr. Shojai, the urban monk who's in Austin,
Oh
Texas,
yeah.
that parallels this, but on a different subject. Explain, Laura.
Yeah, I just think telemedicine, what you're doing, we do that in the GI world, and this is just really a collaborative effort that we see going really across the United States. I think this is where medicine's moving, is getting good care to our patients, right? The easiest way possible. I think you're highlighting how hard it is sometimes to got to go to our doctor, then we got to go to the specialist, then we got to, it's like all these steps to just get, is that even the answer I need? And so I love this approach. It is mirroring for those that know about the work we do at the Urban Monk. This is just something that we're just really want to highlight because so many of our patients, when we do saliva test them and then GI test them, we're doing the same thing, sending the test. Everything's included, just like yours. They get the consult with us and then can provide that treatment, sending them back or wherever they need to go. So I just love the model. I think that it's very patient friendly. I also think it's very collaborative friendly. And that's what I wanted to highlight, why we wanted you to come on tonight. We want to open those doors of collaboration because I see one of the biggest points, Dr. Shah, is just right, where do I send my patient? 'Cause
Right.
I'll send them
Yeah.
to an ENT and they're like, they're fine, or I'll look back at them. One, the patient had to even get the appointment to the ENT. And then if they're not really aware of how you are, I'd like you to almost explain. You don't have to talk about your daughter, but just um,
Yeah.
the connection to the mouth, to the airway. So my world of research and salivary diagnostics, we really see what you are hinting at. I'd like you to dive deeper as that mouth is being dried out. I'm going to say to all my colleagues who test, that's why that TF, the red complex, grows. We're drying, we're acidic. And then the biggest part is the root cause is it because they're not using their nose? And then we're
Yeah.
sitting here trying to do some of those biohacks. I say the easy things of mouth tape when the root cause may be like what you're saying. It's an allergy and this histamine response. We deal with that in the GI. So I know I'm kind of asking a couple of things, but could you just start with why we see cavities and then
Yeah.
why the expansion of that airway? Can you start to connect that? I know most of us kind of understand it, but maybe from your perspective,
Yeah.
you go through what else you look for besides maybe just the uvula or the tonsils. What else do you see? If you could elaborate a little.
Yeah, so I mean, if it's okay, I'll talk about my daughter. So my daughter, I have twins, and she, um, I think she was probably pressed up against the uterus, or she's just a little one. She came a little early, but she has a really high arch palate, and because her palate is high arch, her septum ended up being, sort of crooked, and then she ends up getting nasal obstruction, and so we were worried that she was going to end up not breathing well through her nose. She was going to dry out her saliva. She was going to do all the things that you see on the salivary testing. And then with the dentist for a mom, she was like, if you don't have good saliva, you're going to get cavities, and then you're going to get kind of like a poorly your teeth. I know that it's like, well, I believe it now because I know it's true, but like, I was like, Mom, just by breathing through your mouth, you actually move your teeth. And she was like 100%. And so what we've done for her is we've actually put her on a palate expander to help gently sort of bring that palatal arches up, which is what should naturally happen. And what we're seeing, even just in the early bits, is one, her teeth are fitting better. But secondly, her septum is now getting space to kind of come and be more aligned in the midline, so she will be able to breathe better. And so allergies sort of do the same thing, but in a different way, right? It's an immune dysfunction and they cause inflammation of the tissue. And in either case, whether it's allergies or deviated septum or turbinate hypertrophy or adenoid hypertrophy, or for whatever reason, if you're not using your nose, you're going to breathe through your mouth, you're going to dry out your teeth, you're going to get cavities, you're going to affect your sleep. And then from an ENT perspective, what we see a lot of times is when you're breathing through your mouth at night, your tongue has laxity, right? That's why you can stick it out. But that lax tongue will then flop back and push on the epiglottis and narrow the airway and essentially lead to an obstructive sleep apnea picture. So there's this device you guys might have heard about if you watch TV called the Inspire, where an ENT will literally put like an electrode in the base of your tongue so at night it will move forward. And if you're, 73 and you have terrible sleep apnea and there's no way to get you to lose weight, we should definitely do that. But if you're a kid or if you're young, you shouldn't let me cut your neck open and put a pacemaker in you forever. You should just fix the root cause, which is like get healthy, make sure you're staying fit and try to make sure you're breathing through your nose. But the reason it's interesting is because the Inspire device works by literally moving the base of tongue forward. And so again, if you're not breathing through your nose, that base of tongue is going to block the airway. Um, does that make sense? Did I answer your question, or um, am I
No.
going too far? Yeah,
No, I loved it. And I think there are a lot of people who treat airway, just like you said, whatever appliance, whether it's a Marby, like Saviva, we could go through and name them all. Where
yeah,
do you see yourself fitting in? Like for me as saliva tester, I always say, gosh, get it at the assessment so we know what we're dealing with.
yeah.
Are you just like me, like, ah, but what if they didn't? What if they're in the middle of therapy, doing that?
Yeah.
Can you kind of talk us to both those pathways? Like what is ideal? And then if somebody already is, like, how might that be different?
Yeah. So, one, if anyone's in Denver, we're always happy to see your patients. And so, like in our physical practice, we have great relationships with our local dental colleagues, and it's lovely. They'll send them at, either in the beginning when they get that first CBCT and they're like, oh, the airway's narrow, or they'll do the salivary testing and be like, something's off. Can you go check the airway? Part of the reason we created this telehealth program is because, and I can even see this in the comments, um, unless you have a program that kind of connects oral health and oral systemic health with ENT, not all my colleagues get training in this. Yeah, at University of Connecticut, we have this really cool program where we spend three months with the OMFS team, and so we spend time in the dental clinic. I learned how to pull teeth really terribly, but we do facial trauma with them, and we kind of learn sort of this oral systemic health connection. But I think even somebody was saying in the comments, like sometimes you refer to the ENT and they're like, take Flonase, and they just send them out. And it's frustrating. And it's probably frustrating for you guys because you sent your patient there and you didn't get a good experience. And so part of what we wanted to do with this telehealth program is like, for at least allergies, what we can do is you guys can do the testing, and allergy is completely telehealth based, right? It's a history based diagnosis. I don't need to stick a scope in there. And so we were meeting with patients all across the country who had been maybe not getting the care they wanted from the local ENT, who was just focused on surgery. And we were willing to do non-surgical options like immunotherapy. And someone had asked, is this a customized drop? And it's exactly what it is. So, Laura, if you took it and you have a dog and a cat allergy and a cedar allergy, your immunotherapy only needs to include those. We don't need to put you on something else. It has to be customized for you. And so the testing is sort of our first step. And then the question is, when should you do testing? And so, at our clinic, if someone comes to me and they're in my office because they have nasal obstruction, we almost offer it routinely. In fact, United Healthcare won't even let us do sinus surgery until we've done allergy testing on any of our patients. So we put it up front. We say, look, if you think you're having chronic nasal obstruction, we should check to see if allergies are a role. Just like Laura, you're talking about putting salivary testing up front. And so we have some providers who will have the patients come in, they'll do allergy testing, they'll do salivary testing, they'll do a CBCT, they'll do a home sleep. They kind of do this whole panel on the patients to give them a really comprehensive airway assessment. For some patients and for some practices, that kind of makes sense doing it all up front. And then for other practices, it's more of like an a la carte. Like they'll talk to the patient, they'll say, okay, we're gonna do a salivary test, and then they'll talk to them a little bit more, and they'll be like, now that I've seen you for a year, you keep telling me that every spring you're using, your antihistamines, and maybe now I'll put in the allergy test. We're happy to see your patients at any point in their journey. Our goal is to just be the easiest specialist you guys work with because we hear this story all the time of like, we sent to somebody, they didn't understand the connection, they were just pushing for surgery. And one thing we always tell is like the nice thing about a telehealth practice is we'll never push for surgery. We're only going to offer allergy treatment if it's appropriate. And for some patients, it might not because sort of like what you guys have probably seen with oral appliances. We have to vet these patients. Like immunotherapy is not an overnight treatment. It's not like a pain pill that you take and you feel better. It's a long-term treatment. And a lot of my partners and providers in our platform are really trying to make sure patients understand like, hey, this is something that like it's going to take some time. You got to invest in it, but it will change your immune system slowly. And so similar to you guys, we're looking for patients who understand and who want to kind of go on the right journey.
Mm.
What is that average time? What would you say? I know it's very
Yeah.
individualized, kind of like the GI world.
Yeah.
People are doing the same thing in the oral GI, right? We are asking that
Yeah.
people up front, informing, hey, that's why we tested. This is like a longevity journey to get you back to health. It didn't take us overnight to get here. We're not going to get there overnight. But what would you say, maybe you have some categories of patients that you
Yeah.
put in, depending on.
The average Yeah, so the average patient is going to start to notice initial improvement in 4 to 6 months. They'll start to feel like their allergies are starting to get a little bit better. Somewhere around a year is when patients are like, wow, my needle's really moving. Like I'm really noticing that I'm taking less antihistamines. I'm feeling much better. And then the treatment protocol tends to be about a 3 year um, uh, treatment protocol. For most patients, it's 3 years. Some patients have to go a little longer, but the average patient is about 3 years.
And my follow question to that is, I know we're going to get to some other questions in there. I'll go through and ask those questions. I know some more people are coming in, but I just want to know, will you help them through that phase of like that? I'm just going to pick on the typical like histamine. If somebody is on some of these medications, helping them wean off, is that in their treatment?
Yes.
Some people are
Yeah,
asking
the
that.
goal.
Yeah, how
Yeah,
do
the goal is always to start them on saltwater rinses and maybe an antihistamine in the beginning if they're miserable. But our goal is always to get people off antihistamines because, antihistamines are great drugs. They're over the counter. They're safe. They're great if you have an allergy reaction. But long-term usage of antihistamines has some side effects. There's some concerns about the long-term effects of it. It's a drying thing. It's really tough on your voice. It's tough on your mucous membranes. Um, you know, most things in the body are done for a reason. We make mucus for a reason. It has a protective purpose. And so if you're constantly drying it out, just like if you dry out saliva, it affects the nasal membrane. What I would rather do is retrain your immune system so it doesn't overproduce mucus to the wrong stimuli, right? If you have a bacteria in it like strep or staph, like you should be washing it out with mucus. But every time you see grass pollen, you probably shouldn't because grass pollen's not trying to kill you the way a strep or staph infection is. And that's what we want to get your immune system back to doing.
Great. I'm gonna ask you a couple questions in there. I do want to make sure we get to the questions and then that may lead
Yeah.
to conversations. But one of the first was, can you comment just on the food sensitivities that might
Yeah.
associate with some of these allergic rhinitis,
Yes.
sinusitis
So
having?
So food sensitivities can certainly affect your upper airway and they can cause mucus production. I would say from our perspective, we only treat environmental allergies, and here's the reason why. It's purely from like a safety perspective. Um, if you give someone who has a cat allergy some cat dander, they're going to sneeze. But if you give someone who has a peanut allergy a peanut and you're on a Zoom call, they could die. And so our providers will only do environmental treatment via telehealth. If someone needs food allergy treatment, you do need to go see somebody in person because anytime you're doing an updose, you just need to be around just in case to make sure they don't have a bad reaction. Um, the risk of anaphylaxis with environmental allergy treatment is 1 in 100 million, and we have not treated 100 million patients, so we've never had anyone have anaphylaxis. But with food, it's much lower. And so we focus at Winley only on environmental because that's what we feel is the safest thing we can do via telehealth. But I definitely think environmental foods and food definitely have some relation. It's always worth like if you think your patient has food allergy, thinking about that as well. And then I know somebody asked like, does the sublingual have to be targeted? Yes, Taylor, it's definitely targeted exactly to the patient. There are sometimes we'll use classes. So if someone's like has a bunch of trees, we'll sometimes give them a tree mix because we'll be like, we want to treat this whole region of trees, but in general, we want to target it. And then someone had said like, yeah, like, oh, this is a great example. Like I send an ENT, they just give them Flonase and just outgrow them. We are happy to take those referrals because those patients look, there's nothing. I think what my hope is those ENTs are trying to say like, hey, we shouldn't do surgery, but not all those ENTs have started a sublingual program, and maybe these are patients who can be put on something to start making progress while they're growing, because many patients don't just want to wait. And I think
Let
somebody
me
asked about
oh,
oh yeah, go ahead.
let me ask you, Manan. One of the things we have spoken about a lot is research that was done at Stanford that was showing that many children have enlarged tonsils because of mouth breathing,
Yep,
dirty air, unfiltered, unpurified air. And when they are able to get their mouth closed and start breathing through their nose again, often their tonsils would begin to shrink in a positive way without having
yep,
to surgical removal. And yet, for many physicians, ENTs, they would see that problem as one that you pick up on the playground. And it's just colds being shared by children seasonally and over again through time. When you look at the nose and you think about congestion, someone says, well, I can't really breathe through my nose. It's so congested. Um, One ENT may say, well, you need nasal surgery.
great.
Someone else may say, well, let's look at allergies first that may be causing inflammation and address the allergies
The root cause, yeah.
surgically and see what happens. Does that fit? Is that a parallel that we're talking about the swollen tonsils and mouth breathing and the swollen nose, we'll call it,
Yeah,
and allergies?
yeah. So absolutely, what we see is, that was one of the studies that you kind of cited in there is when people have allergies, the tonsils get swollen up, and when you put them on anti-allergy medications, the tonsils will sometimes decrease in swelling. But then the question is like, why would you put them on singular when you could actually fix the root cause? Like, why wouldn't we retrain them so they don't have to have allergies and try to avoid it? Now, of course, surgery has its role. Look, I'm a surgeon. I love doing
I love
surgery.
doing surgery.
But I tell patients like the goal is to not do it unless we absolutely need to.
Yeah. Yeah. So step one for nasal, I mean, even things like visual cone beam, deviated septum, and obstruction. Are you still going to start with allergies and see? I mean, even if it's pretty blocked, or is that just a dead end?
So I think if it's absolutely obstructed, like if you see the
Yeah,
septum is totally deviated, then like it depends on the age, right? If they're above 18, I'm like you should think about getting it fixed. Below
yeah,
18, I try to give them a little more time because as their face grows, maybe it'll straighten out and they'll have more space, kind of like with my daughter. Um,
yeah.
and then so below 18, I'm always like, let's just try to optimize what we can. Let's do nasal sprays, let's do allergy testing, let's try to decrease the inflammation and then give them time to grow. Once somebody's older, if it's mechanically obstructed, no, I think surgery is definitely fair. But I always think like you should give patients the option of saying, like, look, it depends on how severe this is to you. If you're miserable, we can go straight to surgery. If you're not and you want to try something medical, why don't we try to do allergy testing first and then give the patients a choice? One of the things I tell all my patients is my job is not to tell you what to do. It's to give you a bunch of options, tell you what the pros and cons are, and see which one makes the most sense for you in your specific life. Because like every patient is different and they may have different beliefs and different goals. And my hope is to kind of meet them where they are.
Mhm. Laura, are there other questions in the chat that we should?
Yeah, I think a lot of people are asking you about those nasal, like actually,
Rinses.
yes, your nasal rinses. And really, the comment is like, what is good nasal hygiene? Which one? So that one keeps coming up. If you could kind of go
Yeah.
through both those, like, what do you consider good nasal hygiene? And then what
Yeah.
specific kind of nasal rinses?
Yeah, so I always say if, our first line treatment for patients who are getting sick or patients who are feeling like their nose is obstructed is always a saline mist can or saline rinse. Super simple, easy. It's like taking a bath for your nose. You're just cleaning out the allergens and things like that. Not everyone has to do the whole like neti pot going up and around. I actually can't do it. It kind of freaks me out. I just use a saline mist can, and all I'm trying to do is get some humidity up there and then blow my nose. Um, then I tell patients, okay, if you have allergies, like, fluticasone for a couple weeks during a season, totally safe, has a slight risk of increasing your risk of nosebleeds, but like temporary, totally safe for a couple weeks. I don't always want people to be on it for years and years, but totally safe for a couple, weeks. The other thing is if you're runny, there's a thing called Astapro. It's over the counter. Very, very, very simple, easy, simple solution. And then there's prescription ones like ipratropium bromide and things like budesonide that we can go to. So I always tell patients like, it's always safe to start with the saline mist can. Do you want to do it in the evening, in the morning? Sorry, in the morning, in the evening. So like before you leave, everything you're breathing in all night. And then at night, you should kind of just, it's like brushing your teeth. I actually like, both my kids have a little saline mist can that they brush their teeth and then they spray it in their nose. And one of my kids like water picks her palate thing. So all these things are good. Someone said about steam inhalation. Yeah, that's fine. The whole thing is if you get humidity in there, it loosens things up, and then you give a good nose blow and you can get it out. But for some people, that's not going to be enough, right? I mean, a lot of my patients, they do all these things. It doesn't work. That's why we put them on immunotherapy because we really want to make sure we're optimizing their health.
Mhm.
I really like this question. Somebody's asking, most patients have those certain symptoms like the runny nose, all of that. It's like you say,
Yeah,
they're saying, hey, what about people where you kind of think they have allergies, but these patients look like, they're like denying that they don't have any allergies. Like, no, I don't have a runny nose. No, I don't think I sleep with
yeah,
my mouth closed, all that. And you're like, you look like you have allergies, right? Maybe the dark,
yeah.
like the whole thing, inflammation or the CBCT. How do you go about that with them?
So for those are the patients who, when I have a high clinical suspicion, I'll just say, like, let me just do a test. Let's see. And oftentimes when patients see the data staring back at them, they're like, you know what? Actually, I do seem to have some trouble in the spring. I think one of the challenges is like nobody wants to have a disease, which I love, right? I love that people want to be healthy, but sometimes you have to identify what's really going on so you can get them to being healthy. And so for a lot of these patients, I'll say like, hey, why don't we just try a gentle test and then go from there. And sorry, someone was asking, is it not safe to use Flonase daily for years? It like technically is. There's been studies where they look to see if it affects like the HPA axis, like does the steroid affect your pituitary gland, and it doesn't. But I mean, I just tell patients like your goal is to not be on any medication forever. So, if you're on Flonase for years, maybe you should get allergy tested and just treat the root cause, right? Or if you're inflamed because your turbinates are massive, at some point it's better to like just go get your turbinates reduced by an ENT as opposed to taking a nasal spray forever. Um, I don't think there's technically anything wrong with it, and there's been pretty good studies to show that it's safe for long-term usage. But I would say my general bend is like try to get off meds, be natural.
So I have a little challenge question. I heard you say, well, if they're under 18, I'm going to use their growth. Let's fix the root cause. How are you feeling with adults who are doing the expansion, whether it's Marby or,
Mhm.
all we could name
Yeah.
again,
For
giving them an opportunity? Do you see, like me, I have a crooked
yeah.
nasal. Last time I get to hide that with my glasses, right? Tonight, as you're looking at all of us. But how do you feel about that? Watching this new emergence, because I think more and more of us are treating adults or going into that whole airway with our adult patients. I'd love to hear your take on that. And again, like for this, when we see that, how important is it to be treating that at the same time?
Yeah. I think for adults, so for adults they have the choice, right? So some adults, like we have a bunch of patients who are kind of doing a palate expansion through Vivos here, and they're like, hey, my septum's deviated. And I'm like, all right, but if you're doing this treatment, we should give it time to see if it works. For kids, I'm just a little pushier to be like, let's avoid surgery because we know they're growing. And so like, if a mom comes in with her 12-year-old, she's like, I really want to do surgery. I'm like, I just think we should wait a couple week, a couple of years because like the kid's going to grow and it might change. If an adult comes in and they're like, look, I really want to do surgery, I'm like, look, you're an adult, you can make your own choices, and there's no room for growth. But I think it's totally appropriate if they're trying a different treatment to give them some more time. I'm just probably, I think I push back less on an adult who's like, hey, I want to just breathe better, I want to do surgery than I will with a kid.
And if that's the case, would you do that after their treatment? So if somebody is doing that whole palate expansion movement forward as the ENT, do you want them to have completed that? Is that the
Yeah,
best
I mean,
for them to?
if they are if they're working with an oral care provider to try to expand their palate, I do think it's better to wait. I mean, and of course, I'm speaking in generalities, right? Sometimes, there's certainly a patient just like 3 weeks ago who's in treatment, and the dental care provider was like, "Can you just straighten his septums?" Like he's just spitting out his appliance, I think, and I was like, "Yeah, that's fine." Like, it's all about case by case. But I think if you're putting in the effort to increase the space, you might be able to give yourself more space for your septum. So like you should wait a little bit if you can. Um, but if you're bothered by it, then, if you're above 18 and it's not like your face is necessarily going to grow rapidly in the next couple of years, then you have the choice. And so I tell patients, here are the pros and cons. Like the pros of waiting is maybe you don't have to go through surgery, and that's awesome. The cons of waiting is you might be a little congested for a little bit longer, and the patients kind of get to decide with me.
Mhm.
Talking about some of those signs and symptoms, somebody asked there, this constant dull
Go
headaches. I
ahead.
know we could
Yeah.
head into that with
Yeah.
the airway conversation and
Yeah.
jaw.
So
What's your take
it,
on?
there's so many things, right? Like you said, it can be TMJ, it could be sinus inflammation, it could be allergies causing inflammation. That is somebody who I will oftentimes like. The headache is a tough symptom, and so I will oftentimes have them go get a physical in-person exam. Now, if they test positive to allergies and they want to try, of course, like it's totally safe. But I do think if it's like you're having a headache, it's worth having to do nasal endoscopy or maybe a CBCT or an in-person exam with a provider to check. Versus if somebody comes to me and they're like, every spring my nose is runny and my oral care provider is telling me that like I'm spitting out my appliance and I have a positive test. I'm like, let's do it. Let's go. I'm not worried. It's clearly allergies. And so I'd say, where we try to be safe with telehealth is like if we really try to dig into the history to make sure we're not missing something, right? Because maybe somebody has nasal polyps and that patient should go see an in-person ENT. And so our care providers try really hard to just sort of like parse out like, does this sound like allergies? Is that somebody who we're safe to treat totally via telehealth, or is there anything, that's a red flag? But most of the time, the nice thing is like if you have a dog allergy, you don't need to get a scope. You just need to take dog pollen for 3 years and then buy a dog.
Mhm.
Yeah.
Man,
You
would you go through for us as an ENT allergist and talk to us about nasal pathology and kind of
Yeah.
what are the major ones and what are the primary ways that you would address it? What's safe? Are there things that have traditionally been done that now are kind of not being done so much anymore because they haven't been effective. Just what's the evolution of your specialty that we could learn
Yeah.
from?
Yeah, I would say you know, the biggest thing to think of, there's like sort of three buckets I think about with the nose, right? There's either a problem with the lining, which is allergies, right? The actual nasal lining is getting inflamed. For that, immunotherapy is the cutting edge. It's the new thing, and it's sublingual immunotherapy, whereas shots used to be traditional. Then there's the structure. So traditionally, structurally, it was like if you had a deviated septum or if you had inferior turbinates, you would go to surgery. Nowadays, we can do a lot of these small procedures in the office. We've actually learned so much from our oral care partners. Like lidocaine is a lovely drug, and if you could pull somebody's wisdom teeth out in an office, like we don't have to like just shrink the turbs under anesthesia. And so we do a lot of in-office procedures for turbinate reduction and things like that now for patients with obstruction. And then the last thing is then the sinuses, right? So it's like you're kind of going from inside to out. Um, for sinuses, again, now we can do balloon dilations in the sinus in the office. So traditionally, patients who had, chronic facial pain and pressure or chronic sinusitis, we would take them to the operating room. We'd have to drill out their sinuses so they could drain into the nose. Now we can sort of just like the angioplasty, we can put a wire in, put a little wire with a balloon in, put it right in the sinus, dilate it, and drain them in the office. And for certain patients, it's a really good thing. And probably the most recent new thing is this thing called Rynair, which is for patients who have that chronic runny nose. Um, we know it's because there's a nerve, by the sphenopalatine ganglion that basically triggers the mucus producing goblet cells in the nose. And so there are a couple different companies that have devices. I think there's the Neuromark, there's the Rhino, and the Clarifix. And basically, these devices allow us to disrupt the nerve connection between the brain and the goblet cells. And so for patients who are like, everybody knows that person who always has a box of tissues, or, the older lady who's walking around with a handkerchief. Now we can actually just turn that off mechanically. Now, it's always worth trying to do it medically before you get a procedure, but these are like 10, 15-minute procedures in the office that change people's lives.
Amazing. Thank you. That's very helpful.
Yeah.
Tell us about when you hear criticism of certain nasal surgeries of, they upset the mucus lining, I mean, in the membrane lining, and now they've got chronic issues as a result of a procedure. What's that could go wrong?
Yeah. So it depends. So if you look at I'm going to zoom out. The top line is it really depends on the technique, right? Surgery is a tool, and if the tool is used in the right way, you can get incredible outcomes. And if it's used in the wrong way, you can get absolute madness. And so now I'm going to zoom in a little bit. If you look on the inside of the nose, there are millions and millions of cilia, and the cilia beat, and those cilia beat from the inside of the sinuses towards the sinus ostia and back into the nasal mucosa. And so if you have mucus in the nose and the cilia beat, it kind of beats and pushes the mucus from inside the sinus out into the nose, and it either gets blown out or goes back down the outside. Sometimes when people will do surgery, unfortunately, they won't dilate the area where the cilia are naturally beating. And so there's a thing called a recirculation phenomena, which is super frustrating, where if the surgeon goes into the wrong, like kind of just pushes into the wrong area, all the cilia are pushing the mucus one way, and now they've made a hole somewhere else, and it will actually like drain back into the sinus. And you can actually look in these people's noses with a scope, and you see that the mucus lining is disrupted. And instead of the cilia kind of working together, they're actually getting their sinuses worse. That is something that's like a technique issue. And so it's something that if you go to a well-regarded, well-trained surgeon, they should be thoughtful about this. And I always tell people like, that consult it's an interview, right? If your surgeon's in a rush and doesn't want to talk to you and doesn't seem like they're willing to explain stuff to you, you shouldn't let them cut you. Um, because the level of patience they have now, it's only going to be a little bit less when you're asleep.
Hmm. Hmm. Are there other questions there, Laura, that we want to talk to Manon about?
I think we,
Learned it so much. We appreciate it so
Yeah,
much.
no, this is awesome, guys. I really
We've
appreciate
had
your time and
a full
such a
day
pleasure to connect with
and
you
a
guys.
machine, a full day in the OR and machine broke down today. If anybody can relate to that in the middle
Yeah.
of a procedure where they had to get somebody to come in and help. So we need
Yeah.
to send you home pretty quickly here.
I
Well,
would
guys,
like
I really
to,
appreciate your time. Yeah.
yeah, I would like you just to go through. A lot of people are coming in late, Dr. Shah, so
Yeah.
I would love to just cover one, how a patient could just come to you if that's still available versus, hey, I want to be affiliate. There are people asking, is it overkill if I sent you a CBCT and the saliva test and all that? Right. I want you to kind of
Yeah.
cover both pathways, especially
Amazing.
people who want to do telemed with you. Um,
Hmm.
How easy is that? And what do you want from us as the dental side sending to you?
Yeah, amazing. So I'm gonna put the email in here. Um, Here's what I'd say, and I'll put my own email in here too if you guys have questions. Although I will be honest, I'm not the best at email. My inbox is madness. But um, if anyone is interested in adding allergy testing into their clinic, if they're doing salivary testing, it's a great sort of adjunct, or if they're doing, CBCTs or something like that. We are always happy to send you guys kits, and work with you guys, and our care team can get you set up. And that was one of the greatest parts about going to RMDC with you guys is like we were able to partner with so many providers across the country, and it's been really fun. Um, and we've been getting great feedback because then they're able to do the testing with the patients right there in the clinic. Sometimes they're charging, sometimes they're not. Sometimes it just depends on how their clinic is set up. But then we get the patients and we're able to give the patients this continuity. And the patients feel like, man, I went to see my oral care provider and I got this such as like a really comprehensive workup. And I got to see a specialist online, like from my house. It was great. So we're always happy to do that. If somebody just wants to see us, they can just go to windley.com, and I'm pretty sure I hope there's a button, there should be, if our marketing team is doing their job, where they can just sign up and schedule a consult. And it's very simple. Um, and so we're happy to see patients in either way, whatever's easier for you guys. Um, and if anyone has any questions, I'd love for them to reach out. And again, like the way we do it, it's very simple. The allergy testing can be done by you guys, or it can be done by us if you just want to refer them to us. And then the patients, based on the allergy test results, we will create a customized allergy treatment plan, which is a sublingual drop. We ship that drop to their house. They're basically taking a small dose of what they're allergic to, and over time, it desensitizes them. That's going to help their nose have less inflammation, help them breathe better through their nose, help them sleep better, and it's going to help all the care treatments you guys are trying to do work better.
Awesome. Thank you so much. I just want everyone to
Hey
hear how
guys.
easy it is, how well you take care of the patients. Really, we can just turn things over to you. And I think that's to me the beauty of really telemedicine and collaboration is being able to partner with somebody that we know all those things that were coming early on. My ENT says this, some allergist says that. It's just to know
Yeah.
you're speaking our language, you do understand the dental background. And so we appreciate that so much. Having an avenue and for our community who is doing all of this to be able to partner with you if they choose so, just to make it easy, not only on themselves, but ideally their patients to get the best outcomes. So thank you so much.
Yeah.
Awesome, guys.
And
Tonight.
thank you for putting a face to the service. Now we know you,
Yeah.
personally and have heard from you. But part of it is just trying to up our game all the time, put our team together, and no different than an oral myofunctional therapist, where in my neighborhood, I searched for a couple of years looking for someone to work with. Finally, I was at a national meeting talking to a prominent speaker that's an oral myofunctional therapist and said, "Where do I find somebody in my town?" And she said, "Well, we'll see your patients for you because we don't have to touch them. And so we can consult with them from Denver, one of the folks I talked to, in California. And so I've been working with oral myofunctional therapy with the world's best who are not in St. Petersburg, Florida, but the
Yeah.
patients are getting that service. And I feel the same here is, am I going to send them to Dr., someone I don't know and hope they know what they're doing and they're up to speed and doing the latest thing and doing it efficiently, or work with someone that I do know that we can get them in today and get to work on it. And so great collaboration. And man, thank you so much for taking time to be with us
Yeah, guys. I
tonight
appreciate you
here, late
guys.
afternoon there. But get home
Yeah,
and see your kids and have dinner. And thank your wife for letting you come home late because you're helping us to learn.
absolutely. Well,
All
we,
right.
we appreciate it, guys. Take care.
Okay. Take care. Bye now.
Thank you. Bye, everybody.
I guess we'll just check out, Laura. Our next meeting is in 2 months. And tell us about that. You're going to be speaking about a research project.
Yes, we're going to be actually going through the paper that got published in Frontiers with Dr. Beatty, myself, Dr. Dave Vigorous, and Dr. Cami Haas. We're going to go through the test, treat, repopulate. We're going to actually break down the science of that protocol what was published in there, and actually how to execute that. So all of us will be on, we'll be presenting that to you, answering questions, but really to break down the science of it so that you understand and then actually how to put it into practice. I think that's the implementation part that we want to bring to you, is that we really can reduce these pathogens. That's what these studies are showing. So I'm excited that everyone's going to be on, and we'll be able to have that. So we'll look forward to everyone joining us at the next study club.
Oh God.
There's so
Anyway,
there's so much going on right now before we check out and call it a night. We have had so many wonderful conversations recently. I'm talking about in the last month with people that are doing amazing work. Um, Let me share with you something and we'll close with this. But this was a post on Instagram, and I'll read it to you. Okay, here we go. There is a uh, health and wellness specialist, and his name is Ryan Hawkes, Hawkes. He has a pretty good following on Instagram, and he is helping to set up health and wellness clinics all over North America. He lives in Toronto, and so he put this post up about 2 weeks ago. Let me read it to you. So he's not a physician, he's not a dentist. He's more in the healthcare world. And here's what he had to say. The gut had its decade. Your mouth is next. For 100 years, the mouth belonged to one place, the dentist's office. Twice a year, a cleaning, a lecture about flossing, done. We treated it like plumbing, walled off from everything we call health. It was the one part of the body wellness never really touched. That's ending. The mouth is the front door to the whole body, where food, air, and bacteria enter, where digestion begins, and the microbes living there are wired to the rest of you. A growing body of research links oral health to cardiovascular, metabolic, and inflammatory disease. One 2020 meta-analysis found severe gum disease associated with a 53% higher incidence of type 2 diabetes. And here's the part that should sound familiar. This is the gut health story again. 10 years ago, the microbiome was fringe. Then came the tests, the scores, the personalized protocols, and it became one of the biggest categories in wellness. Oral health is now stepping onto that exact path. Early, at home saliva tests, reading your oral microbiome, oral probiotics, microbiome friendly toothpaste, a market scaling from hundreds of millions toward the low billions this decade. Oral care is going from cosmetic to clinical. And for operators, that's the opening. The gyms and longevity clinics winning right now sell measurements, DEXA, VO2, blood work, the whole optimize your health span stack. The oral microbiome is the next input in it, and it ties straight to the cardiovascular metabolic outcomes you already sell. New data stream, new service layer, and almost nobody's claimed it. This is coming from someone who is speaking to the health and wellness industry, those that are opening up large clinics around the country for health and wellness, but not just gyms with weight machines, but now they're looking at peptides and they're looking at hormones and they're looking at probiotics and they're looking at gut health and they're looking now, he's saying, into oral health. So when I read that post, which was just about 2 weeks ago, I messaged back and said, this is a field that we've been in for a long time. I'd love to talk to you. Within 15 minutes, he texted me back and said, I'd love to talk to you. And Laura and I are going to meet with him probably the end of this month. And so you see how the collaboration between people like the Dr. Shahs in allergy and ENT and Dr. Shojai in gut wellness and overall health and well-being, and now the health and wellness industry, which is not a medical specialty, and us in dentistry are all starting to talk the same talk, and it's that The oral part of health has been ignored. Now we know it's front and center. And the question is, are we ready? Because the public is going to be talking about this more and more. And are we ready for it? And are our colleagues ready for it? And so that's the journey that we're on. But it's very exciting after 10 or 12 years of speaking about this all over the country and people going, that's great for you. Um, to see now that the public, the different professionals are starting to get the picture that something huge has been missing, and it's what we do. The health and wellness industry is going to be the largest industry. It is the largest industry of any, predicted to be by the year 2029 a $9.75 trillion industry, not billion, $1 trillion industry. And we live right in the middle of the health and wellness industry, but do we even know it? Are we even aware? Are we still just thinking teeth and gums? And so I know you aren't, but I just speak to you as leaders in this emerging field that we really are on the cutting edge of something very exciting. And for us that have had to be very patient, to see this get momentum, it's getting momentum now. And it's very exciting. And so um, we're all aboard and the train's pulled out of the station. And aren't you glad to be ahead of the curve? So we'll keep talking about these things and what's new. And I hope it was very helpful to you tonight to learn more about our neighbor, the nose, and to hear about some of the telemedicine things that are going on in that world, such as what uh, what Manan was talking about, Dr. Shah. So yeah, let's check out Laura. I think it's dinner time. But thank you all for being with us. It's been hopefully a great meeting for you, and we'll see you, if not sooner, in 2 months.
Yes, and I did post your podcast there so they could listen to this.
Oh,
They were
great.
asking about Ryan Hawks, but I did want to post that because you're talking about this very thing in that podcast, just for everyone to stay up on what's going across socials, so you can listen to with there, and you can go find also Ryan Hawks that you can go through and look for that on social because it has this big connection. And we're going to bring more and more of that to you over this next 26 and 27 year. So thank you, Whit. Whit's going out there. He's attacking it on all ends, and we're going to bring it right back to this community. Appreciate all of you.
Yeah, thank you, Laura. Good night, everybody.